All right, everyone, let's hope that my internet holds out for this second part of our vascular disorders lecture. We're going to start back where we were abruptly cut off here with the endovascular aneurysm repair slide. And we got down to what kind of the risks of this procedure are. And those are risk for graft thrombosis or clotting around the graft site, stent migration. So technically the stent could move about. Incisional site hematoma from where they went in at the groin site, and then infection, as is a risk for any invasive procedure. Post-op care, whether this is an open endovascular, whether this is an open repair or an endovascular repair, we need to make sure there's graft patency with adequate blood pressure. So if our blood pressure were to become too low, then we're going to have risk for stagnant blood, resulting in clot formation, thrombosis, or ischemia. If our blood pressure is too high, then it's going to cause undue stress at the site of the stent, causing potential for leakage or rupture of the stent. GI status, because of the clamping or the kind of the risk for ischemia from pausing the flow from the aorta, which is what perfuses the GI system. There's a risk for paralytic ileus, and the patient needs to be NPO, good oral care to prevent any kind of infection, monitor for bowel ischemia. So things that would cue you in that the patient was developing bowel ischemia is absent bowel sounds, fever, abdominal distension, diarrhea, or bloody stool. So if you had signs of any of these things, you would pretty immediately want to call the doctor. If bowel starts to die, it can become very necrotic, and the patient's at high risk for sepsis and multiple organ dysfunction syndrome and death from that. So we want to stay away from bowel ischemia and death as much as possible. It's much easier to prevent than it is to fix. Neurostatus, again, we are affecting the aorta. If the clamp time was too long, depending on where it's at, we can have all of these complications happen. So in order to check for the risk for stroke, we're going to monitor their neurostatus, their level of consciousness, pupillary reaction, facial symmetry, tongue deviation, speech quality, grip strength, and compare that symmetry to the other side. Movement of upper and lower extremities, peripheral perfusion status, will be checking repeatal pulses, the color and cap refill of our skin, sensation and movement. And then for renal perfusion status, again, problems from the cross clamp, hypovolemia, or thrombosis could be causes for kidney issues. Monitoring their hourly urine output with a Foley catheter is going to be priority, and getting their labs, CBC, CMP, to get electrolytes and BUN and creatinine. Early elevations in BUN and creatinine can give us evidence of acute kidney injury, which is what we want to stay on top of, identify, and treat early. Aortic dissection. So this is where I was talking about this can get a little confusing. We just went over aortic aneurysms. So what is an aortic dissection? Well, this is where instead of a bulging of all three layers of a vessel, you have three layers of a vessel. And I want to see, oh yes, we can do this. So every vessel in the body has three layers, and they're real tight, close together, right? We have a tunica intima, which is the inner layer. Don't make fun of my artistic skills. You guys know how I am. And here we go. So we have three layers here. The inner layer is the tunica intima, the middle is the tunica media, and the external is the tunica externa. So they're pretty self-explanatory based on their names. In an aneurysm, it looks like this. So this is you know it's hard to write with this mouse too. Aneurysm. I'm not even spelled that right, but y'all get what I'm trying to do here. Aneurysm. There's a bulging of all three of those layers due to harsh blood flow. Ooh, I should have changed the, ooh, here we go. Let me see. Ooh, this is the, ooh. So then we're going to have blood come through here That's the red, right? So there's blood flow, and if the pressure is high, then it's going to keep hitting up against this, which puts it at risk for rupture, right? So that's our big concern here is rupture. Oh my God. Here we go. So this is your aneurysm, right? Okay, now we're going to go to what a dissection is. So here we're going to have our 3 layers again. Tunica externa on the outer, tunica media in the middle, and tunica intima on the inside of the layer, right? All right, so now we're going to draw a dissection. So what's happening with a dissection? This is dissection. That's hard. Boom, look at that. So what has happened is there has been a disruption in the tunica intima. I'm talking about right here. There's been some kind of tear or disruption in the tunica intima. The 2 outer layers here are intact, right? I don't like that. Red is supposed to be our blood, right? So let me change that color. So here is our tear in the tunica intima, and the tunica media and externa are intact. However, the disruption here in the tunica intima is weakening the outer layers, right? So the integrity of this side of the vessel is really impaired because that layer is injured. So then what we're going to see happen is blood's going to flow like it should, but also it's going to leak in here into the tunica intima and go in behind these layers. So here's your picture here. This is a risk for rupture. And then over here, this is going to lead to a risk of rupture. So the same outcomes are possible with both of these diagnoses, but they're a little bit different in their cause. So again, in your aneurysm, all 3 layers are weakened, usually by hypertension. And then over time, the weakening of all 3 of these layers can cause the bulging and hopefully not, but potentially rupture. In the dissection, you have an entire tear in the tunica intima, the inner layer of the vessel, where the tunica media and tunica externa are intact, but you do have blood flowing in here, and then again, same kind of risk of outcome for rupture. So going back to our PowerPoint, so that's what that false lumen between the intima and the media is talking about, that tear injury to the intima causing blood to flow in there. The most common area, we talked about the most common area for an aneurysm is the abdomen, a AAA, an abdominal aortic aneurysm. For a dissection, it's at the descending aorta. So where, let's erase this, clear my drawing. Okay, so here, what am I drawing? Oh my God. Oh yeah, I remember. So here we're going to kind of, here's your heart, right? And then off of your heart is the aorta. So the most common area for an aneurysm is kind of in the middle at the abdomen, AAA. The most common area for a dissection is up top at the arch. Because here at the arch, there's a ligament called the ligamentum arteriosum that kind of holds the arch of the aorta in place. And so ligaments are more of a fixed point. And so there's a higher ability with a trauma, like in an acceleration, deceleration, or like a T-bone scenario where a patient was hit at the side of the car and kind of thrown to the left and right too quickly. It'll cause movement at that ligament and can cause that tunica intima to tear more easily or shear. So that's why this area is more common for a dissection, and this area, kind of below and in the abdomen is more common for a AAA. So, here we go. So again, descending aorta at that arch near the ligamentum arteriosum. Sounds like Harry Potter. That's kind of how I remember it, like a spell or something. Anyways, risk factors, again, high blood pressure and trauma would be the two most common reasons why a patient would experience an aortic dissection, but also congenital disorders, connective tissue disease, and cocaine use. Cocaine use being tied back to high blood pressure, right? Cocaine is an upper. It's a stimulator, so it stimulates increased heart rate and increased blood pressure, which over time could lead to weakening of vessels and dissection. Clinical manifestations are super similar to an aorta aneurysm. The worst pain ever, sharp, tearing, ripping, chest to back. Same kind of symptoms. Complications, cardiac tamponade, which we talked about, fluid increasing around the heart and compressing the heart, or rupture and hemorrhage. We're going to diagnose this with a CT scan with contrast to be able to see that contrast leak through that tunica intima and see the injury here. So this is a better picture than what I drew. These are where dissection has occurred in that inner layer, and it's caused blood to leak out around the tunica media, and looks like it forms this almost aneurysm-like design here. Biggest considerations for aortic dissections and aortic rupture aneurysms are managing their blood pressure. A decreased systolic blood pressure and force to the left. A decrease in the systolic blood pressure will lead to decreased force of the left ventricle contraction. That's a good thing. We want decreased blood pressure, decrease the work that the heart has to overcome, decrease that afterload, so that we're not pushing so much blood out into that dissection. Most common drug that we're going to give here is beta blockers to not only decrease their blood pressure, but also to decrease their heart rate. And the most common drug we give is esmolol IV. There's also ways we can use calcium channel blockers, especially nicardipine or cardine or ACE inhibitors, but esmolol is by far the most common for an aortic dissection, and then they need emergency surgery. Same complications of AAA. So you don't have to memorize two different like treatment, management, interventions, anything like that. You just need to know that the dissection has a bit different of a pathology versus the aneurysm. I'm so sorry, I'm getting tongue-tied here. So that was all for our arterial disorders. Now we're going to move into venous disorders. So the first thing we're going to talk about is thrombophlebitis, also known as venous thromboembolism, or VTE, or DVT for deep vein thrombosis. They all mean the same thing. It's a clot in an external extremity vessel. Risk factors for VTE are age over 40 years, surgery below the waist, immobility, prolonged travel, obesity, pregnancy, heart disease, cancer, clotting disorders, and contraceptives. So contraceptives, clotting disorders, cancer, and pregnancy all have to do with the patient being hypercoagulable. So if you're looking at this triad, Virchow's triad, hypercoagulable means high affinity for clotting. So cancer, clotting disorders, contraceptives, and pregnancy, all of those conditions cause a hypercoagulability. And things like heart disease, obesity, prolonged travel, immobility, surgery below the waist, those all put a patient at risk for venous stasis. And then endothelial injury can occur kind of with any of these things. Something as simple as crossing your legs for too long can cause a minor endothelial injury, which triggers the inflammatory response and the clotting cascade to develop a thrombosis to that area of the vessel. So combined with a high affinity for clotting and venous stasis in that area, this is a recipe for disaster of developing a DVT. And you need to know those things. Signs and symptoms of a DVT are redness, unilateral leg swelling, warmth, tenderness. You can see that here in this picture. This is like what a patient would look like if they had DVT formation. Low-grade temperature, decreased or absent pulses. In these scenarios, you would not massage that area. You would not encourage activity. We would want to discourage that because there's already been formation of a clot. And if we were to massage, or if that patient was to get up and be very active, then that clot could break off and travel to the heart, lungs, or stroke, or to the brain and cause problems, right? So we don't want that to happen. So what can we do to prevent DVTs from occurring? Well, prevent venous stasis. So this is before a patient develops a DVT, right? We're talking about prevention strategies. So have them increase activity, do active or passive range of motion, leg exercises, and this is why we do TEDS and SCITs. Avoid prolonged sitting or standing, and don't have pillows under the knees. That can cause that pressure and cause an endothelial injury. Treat hypercoagulability. So if they have to be prolonged immobility or anything like that, along with preventing the stasis, they may be on a heparin, Lovenox, or Coumadin. Heparin drip, they may need to be on. Therapeutic level for Coumadin for like their INR is going to be 2.5 to 3.5, like we mentioned earlier. And then for a heparin drip, you're going to titrate that based on their PTT, their prothrombin time. So that's what you kind of titrate and determine your heparin dose with. And then to prevent venous injury, we're going to make sure as nurses that we're assessing IV sites well and preventing things like phlebitis, or if they do occur, then we are going to quickly identify that, remove the IV, and let the physician know. And if they have to have pressure on calf veins during prolonged surgery, then we need to make sure that physicians know that and that we're repositioning them as often as possible within that surgery or procedure. Chronic venous insufficiency, so this would be like PVD, peripheral venous disease, these are opposite symptoms from peripheral arterial disease, which we talked about in part 1 of this PowerPoint presentation. So chronic venous insufficiency occurs due to dysfunctional valves that reduce venous return. So all this venous blood is getting stuck kind of within the lower extremities. They'll have chronically swollen legs with a feeling of heaviness or fullness. They'll feel that sensation in their legs. Mild pain that would be relieved by elevation, because elevating their legs would cause that venous blood to drain back to their heart. That, again, is opposite from peripheral arterial disease. They'll have thick, coarse, brownish skin with itchy, scaly skin. Remember, peripheral artery disease is the opposite. It's got pallor and hairlessness, where this is thick, coarse, brown, itchy, scaly skin. And then remember that difference between venous stasis ulcers and arterial ulcers. Nursing management, we're going to elevate legs when at rest. The pain is worse in the dependent position. Compression multi-layer wraps are going to be necessary. Weight control can help with this, help manage it, help reduce pain, increase activity, and if they do develop an ulcer, they need antibiotics to treat infections and to monitor if it progresses to cellulitis. What are we going to do about cellulitis? Well, cellulitis is, just like it sounds, inflammation of the deep dermis, and it's a skin infection that extends down into the deep dermis and subcutaneous tissue. It's often caused by Streptococcus pyogenes or any other organisms. They typically need blood cultures before antibiotics on these. They can quickly spread to the blood and develop bacteremia, so we don't want that to happen. And then, as we see in this picture, clinical manifestations: deep red erythema without sharp borders, and edema. They may weak fluid. Not may, it's usually they will weak fluid, and it's a lot. You put several chucks on these patients' beds because the skin becomes very swollen and edematous, blistery, and those are just naturally going to pop and cause all kinds of fluids to weep. We usually use a skin marker to line out the edges of this so we can monitor if it progresses further. And then they're usually going to come in for some IV antibiotics. Risk factors for cellulitis are elderly patients, patients with diabetes, malnourished patients, or those who are on steroid therapy for a long period of time. It's an immunosuppressant therapy, so that's what puts them at risk. And then presence of wounds and ulcers can easily transition into a cellulitis. Our nursing management, wound cultures and blood cultures, we're going to get those before we start our IV or PO antibiotics. Monitor and treat their temperature if they develop a fever. And if untreated, this can lead to gangrene or sepsis, which could lead to amputation of that limb, or worse, like death related to severe sepsis. So definitely monitoring that. How do we know if the infection has progressed from a local cellulitis to a gangrene or sepsis? Well, the skin's going to look worse. So just like this picture shows, it's going to grow past where you've marked it with the skin marker. And then we're going to start seeing those vital sign changes: increased heart rate, increased respiratory rate, increased white blood cell count, decreased blood pressure if we're getting into a septic shock realm. So monitoring those and catching it early. And then obviously good hand washing for these patients to help prevent worsening of the infection. And that's it for this chapter. So I'm going to sign off. That'll be part 2 of your vascular disorders, chapter 37. And then I'll sign back in here and do our dysrhythmias soon. Thank you so much.